Today's topic is a very interesting topic, and I would like to go through some important developments regarding the COPD disease that has changed in management as well as understanding during the past few years actually. When we look at this first graph, unfortunately, in 2021 only, there were about 4 million deaths. That's about one fourth of the total population of Sri Lanka has been completely wiped out from the world because of COPD. And that's really unfortunate. And at the same time, we can see in this graph, which was actually from a Lancet journal in 2007, which has postulated that the COPD incidence and the deaths will rise exponentially, even when compared to diabetes, HIV, tuberculosis, and malaria coming together. So we are actually facing a huge problem because of COPD, and I think it is time that we look at COPD in a different perspective. So when we look at the Sri Lankan picture, I think we can see in the right side, on the left side corner of this graph, the blue lines. It indicates the admissions to the government hospital sector, and you can see that there is a significant rise on a yearly basis of patients being admitted with COPD exacerbations and needing care for COPD to our government hospitals. And if you are working in a medical unit or ETU or even in the OPD, you will see that this trend is true. And unfortunately, in the pink line, you can see that the deaths due to COPD also are rising exponentially, unfortunately. So the deaths as well as the numbers in Sri Lanka, these are Sri Lankan statistics, even though a little bit old, are alarming. And we have been partners of two important international studies, the BOLD study as well as the Arnold study. And in the BOLD study, one important aspect that we have identified is that there was about 10% prevalence of COPD in Sri Lanka. Even though we thought it might be low, it was about 1 in 10 people in the Sri Lankan population. This might vary depending on where you take the sample, especially in a rural population or in a population where high smoking rates are prevalent. It might be a little bit higher, but in certain population it might be lower, but average 10% of the people are affected with COPD. And in the Arnold study, one important aspect that we have found is that out of these patients with COPD, majority of them, a significant proportion of them, or 40% of them, are in the stage 3, gold stage 3 and 4, that is severe COPD. So probably we are missing patients at the early stages of COPD. And the second important thing is whether our population is phenotypically different. Especially this has been seen in India as well as in Sri Lanka. So I think it's a combination of both, because in the Arnold study per se, we have found a high degree of percentages of female COPD patients, especially after exposing themselves to the biomass exposure. And at the same time, our patients have a significant proportion of bronchiectasis as underlying comorbidity in COPD patients. Hence, they have a tendency for recurrent exacerbations as well as severe disease. So Sri Lankan data is also concerning, to say the least. Now, when we look at history of COPD, I think you know this gentleman. He's René Liniec, who invented the basic stethoscope because of the difficulties he underwent in auscultating, especially female colleagues or female patients. And he is actually attributed the name emphysema, which basically indicates inflation or swelling with air. And it was because that when he did autopsies at that time, he understood that the lungs of these patients were not collapsing, and the reason for the non-collapsing lung is the accumulation of air. And when you look at the bronchi, they were plugged or inflamed with mucus. Hence the name emphysema came, and it has been stuck. But even though it had the name at this time, the population has suffered immensely during the last decades because of COPD. Now, the seminal paper about COPD, when we talk about COPD, is this paper by Fletcher and Peto. It was actually published in 1977 in the British Medical Journal. They have observed from 1950s onwards the Londonians, that means the London working class, who majority of them were smokers, unfortunately, at that time, and he has monitored the declination of reduction of the lung functions, and this is actually a very famous graph. I think all of you have uh, seen this graph, where you start with a normal, apparently normal 100% lung function, and in smokers you see a rapid deterioration, and in due to age you can see a slightly reduced reduction of the lung functions per se. And this study is a very important study because it understood that it identified the causative factors of COPD, like as smoking. It understood that it causes significant reduction of lung function, the time. And the third thing is, when patients are stop smoking, it causes an increasing of the lung function, even though not back to normal. And the fourth thing is, what he has suggested is, especially in smokers, if we identify an early lung functions and deterioration, we can intervene at that time. So this is a very important study. But unfortunately, with this study, we came into a mindset saying that COPD is a unique disease. It has a single trajectory. So it is basically in smokers. Now, even as doctors, we might stigmatize patients as smokers, because when they come as smokers, and you have done it to yourself, right? So that attitude had come, and basically it is thought to be a self-inflicted disease. And at the same time, we were fixed with the fixed airway obstruction picture with FE1 to FEC ratio of less than 7. Even if it was more than, if it was 71, we are not considering COPD. And then there we thought that it is an irreversible disease. It's almost like a death sentence. I can remember my house officer days. I went about 20 years back in the same hospital, this Hales Hospital, where in a COPD patient comes, none of the ICUs accepted the patient, and unfortunately, the only thing that we can have given is the nebulizations, hydrocortisone, and aminophylline drip, and unfortunately, some of them died during the admission. So this set has changed now in 2025. So now I'm going into the new understanding of the COPD. Is COPD a unique single entity? The answer is possibly no. The reason is that all the beings are an interaction of genomes, the environment, and time. So we call it getonomics. So basically, when you look at this graph, I think you can see from the genetic predisposition of having COPD, and the predisposition starts actually before conception from the mother's and father's genetics, and then the mother's and father's habits while the baby is in the womb. So if the mother and father, the mother is exposed to passive smoking, even biomass fuel, in utero, if the mother is malnourished, especially if the mother is a smoker, then the beginning of the COPD starts exactly there. Then recurrent infection, poorly controlled asthma. Then after that, they are exposed to allergens, the patient's lifestyle, the modifications, the alcohols, and then the smoking, as well as in the modern days, we have to think about vaping as well, which is also a feature, is a risk factor for COPD, and then pollution and accidents. So these changes the genetic structure and genetic transcriptions during the time, as well as our age process also will help it modulate the process as well. Hence, it is not a single entity, and you can imagine the multiple combinations of phenotypes that can happen in COPD. This is exactly what is happening in COPD. Like asthma, COPD has many phenotypes, and identifying these phenotypes is very important in managing individual patients. So we are again going into an individual patient-based management. So one of the important aspects of this graph is that we have started at 100, and I think Asela is with me, and he's a sports medicine expert, and one of the most important limiting factor in athletes is the lung, and because in a female up to 18 the lung grows, and then after that it's stabilized, and in males up to about 24 the lung is functioning. So especially adolescents, exposure to smoke and vaping should be completely discouraged. And the other thing is, once you reach that maximum, then there is no way that you can enhance. You can enhance the cardiovascular, the muscle, as well as the other aspects of sports, but the lung stays the same. But anyway, after you reach this 100%, then only you deteriorate. So there are two plateaus. Some people reach 100%, but some people doesn't reach 100% even at that level, because they will have multiple problems during the childhood or the genetics. And furthermore, now we have this novel understanding where there are people who might have increased lung functions in some people. And the problem with this is that even though they start smoking and deteriorate, if we catch them up here, we might interpret them as a normal person even though they have COPD. So there are various implications and various understanding about these graphs that we have to understand, right? So is COPD is a unique entity? I think I have proven that hopefully it is basically an interaction between genetic, environmental, as well as time factors. Hence the name getonomics is the word, and it creates various types of phenotypes and endotypes. Hence we have to go on identifying these patients and then treat them accordingly. Okay, so the next is that, does this have clinical implications? Yes, in the 2025 GOLD guidelines, this phenotypic variation is understood and is recognized, and does this have importance in treatment options? Yes, if the patient is having specific genetic abnormalities like alpha-1 antitrypsin deficiencies, you have to treat them. If it is smoking, you have to advise smoking cessation. If there is biomass fuel exposure, you have to address that. And I think if there are OPD doctors and medical doctors, there's a very important thing that we should ask our respiratory patients about the biomass fuel exposure as well as indoor air pollution. And we try to change the world and we try to change the environment pollution in the country, but our rooms are sometimes polluted more than ever. So it's very important that we clean our houses and as well as our rooms. And the other thing is, if it is infectious, especially in the Sri Lankan context, tuberculosis is a very important aspect that we have to think about. Asthma COPD overlap or together is another important aspect. Chronic asthma per se is a risk factor for COPD. Abnormal lung developments in the congenital abnormality and unknown causes are there, and Sir will further clarify these in his lecture next. So why are we looking at a FE1 and FVC of less than 70? Is it feasible? Is it useful? Yes, it is still useful. So in current guidelines also suggest that FE1 to FVC ratio of more than 70 excludes COPD, but the important thing is, especially you have to look at the flow volume loop in these patients, but because sometimes there might be air trapping and there will be a low FVC giving you a high FE1 to FVC ratio. So if we are seeing a coving in the flow volume loop, it's always better to do a variable test or do the spirometry after nebulizing or giving salbutamol 4 puffs and checking it about 10 minutes later, or ipratropium 4 puffs and checking it about 30 minutes later, the variability of these patients. If the FE1 to FVC ratio is less than 70, yes, we have to look at the variability. And if it is a fixed variability, if it is fixed, then it is COPD is the most likely possibility in this patient. But if the FE1 FVC ratio is more than that, probably it's a variable airway disease like asthma. And when asthma and COPD is coexist together, asthma COPD overlap, we have to have exposure history together with our variable factors, or the guidelines or the cutoff marks will change, cutoff points will change. So in a normal person, we look at a 200 milliliter variability, but when you have asthma COPD overlap, you look at a 400 milliliter variability in these patients. But FE1 to FVC ratio less than 70 still sticks, and it's a very important factor in diagnosing COPD. And spirometry is a very important attribute as well. And is there a way of measuring the severity? Yes. Still, we measure the severity by the GOLD 1, 2, 3, 4 to a certain extent. And if it is mild, the FE1 is more than 80, and then the 50, 30, and less than 30 becoming as severe COPD. But these have problems because sometimes the obstructiveness might not explain the patient's symptomatology or the risk of progression. But to a certain extent, these staging matters. So especially, I told you previously, in Sri Lanka, stage 3 and 4 is predominantly there. So when you look at these stage 3 and 4, they almost behave as a different disease entity, because they have significantly low amount of airways and cross sections of the airways in the lungs when compared to gold 1 and 2. We expect a gradual progression or decline, but in these patients in stage 3 and 4 they have a significant reduction. So they probably represent a different phenotype. And especially when we look at their immunological underlying immunology in these patients, we thought that COPD is because of exposure to noxious agents and causing a neutrophilic inflammation. But especially in the patients with stage 3 and 4 disease, there seems to be a lot of innate immunity, acquired immunity coming into the picture, and they have lymphoid follicles in these terminal bronchioles causing permanent dilatation, and hence the immune and the pathophysiologic mechanism between the stage 1 and 2 and 3 and 4 seems to be different, and hence probably the targeted treatment will be different in future for these two groups. And the most important thing is it might miss. So if we stick to FeV1 to FVC ratio, it might have, basically we might be able to identify these stage 1 and 2 and 3 and 4, but sometimes we might miss some individuals who might have adverse outcomes. So one such entity is the pre-COPD group, which has basically three main important aspects. The patients have symptoms of dyspnea, cough, and sometimes even they have exacerbations, but the FeV1 to FV ratio is more than 70. Do they have COPD or not? That is a problem that we have to address. The second thing is we do a HRCT suspecting that this patient is having some other lung disease, and then we see emphysema, bronchial wall thickening, and terminal bronchial dilatation. So then there are structural changes incompatible with COPD, but they will not have the FeV1 to FVC ratio, and they have the same risk of progression and sometimes the symptomatology as well. Sometimes they will have a low DLCO with hyperinflation, but with normal FeV1 to FVC ratio. Hence, FeV1 to FVC ratio per se will not catch patients with COPD completely. And there's another important thing, this one, which called the early COPD group, where they will have FeV1 to FVC ratio of more than 70, but they will have symptoms of COPD. Another group is this group, where even though they will have a less than 0.7, they might be completely asymptomatic, right? So there, because the CAT score will be less than 10. So this group also, the patient, if you check the FeV1 to FVC ratio, it will be less than 70, but they will be asymptomatic. And that is the group that we call preclinical COPD. So we have the pre-COPD and the preclinical COPD group, which we might miss if we don't see them if we just go into the FeV1 to FVC ratio. And then another important aspect that we have found is the PRISM group, PRISM, where the preserved ratio, they had the preserved ratio of FeV1 to FVC ratio of 0.7, but when you look at the FeV1 ratio, it is less than 80. So there, this group basically might have a different phenotype. Right? So the PRISM group is FeV1 to FVC ratio is more than 70%, but the FeV1 is less than 80%. So that group has a low FeV1, even though there is no characteristic obstruction. Do we have a clinical implication to this group? Yes, because there are phenotypes of the COPD clusters. So I will not go into details because of the time, but these PRISM group, we have three actually phenotypic clusters, which behaves completely differently. And hence, even though this category might not come into the COPD classification, we have to address these patients, or else their outcomes will be very poor, especially the cluster 3 who have a high BMI, the obese patient with diabetes and other cardiovascular diseases with low TLCO, and then they will have increased segmental wall areas as well. Right. What is the progression of PRISM? And you can see that some of these group, the PRISM group, can progress into COPD group 1, 2, 3, or 4. And at the same time, to make matters complicated, some of these PRISM patients can completely have a normal, they can convert to the normal lung function as well. So it depends probably during the exposure levels as well as underlying factors. And FeV1 to FVC ratio of less than 70 may not completely reflect the symptom burden. For the patient, the most important thing is the symptom burden, and it might not reflect the risk of progression as well. Hence, we have MRC score as well as the CAT score, which is CAT score is, I think, more appropriate in the COPD setting to be used in all of our patients. So because symptomatology also matters. So why is that? Because the baseline CAT score might predict the exacerbation rates. So in patients who have a higher CAT score, they have a higher risk of exacerbation. Why are we worried about exacerbations in these patients? Each and every exacerbation is considered as a lung attack. We talk about heart attacks, but it is basically a lung attack. The lifespan reduces markedly, their lung function reduces markedly, and each exacerbation have irreversible consequences for the patients as well as his respiratory symptoms. So hence, you have to prevent exacerbations. And one of the pointers of having a risk of exacerbation is probably the CAT score in these patients. So we have to take that into consideration. And taking all it into the picture, the current guidelines suggest that we have mainly categories A, B, and E, not A, B, C, D like previously. We give priority for the exacerbators basically, because we have to prevent the exacerbation as much as possible. So if a person has more than 2 exacerbations or 1 exacerbation needing hospitalization, the patient becomes a E or exacerbator with a higher risk, whatever the FeV1 to FVC ratio, FeV1 level says. What are the therapeutic implications of this outcome? So this is a very important summary, and it's the easiest actually to remember. So any patients with group E should be on a long-acting bronchial beta agonist and a long-acting anti-muscarinics. The Sri Lankan context, what we have is the long-acting anti-muscarinics currently we have is tiotropium, and the long-acting beta agonist we have formoterol as well as salmeterol, but unfortunately we don't have it as a unique clinical entity. And our council last year worked hard to get these into the Sri Lankan armamentum. So hopefully within the next year we will be able to get it into the picture. So, or else if the patient is having mild disease, that is not symptomatic, a bronchodilator as required is the one that is prescribed. And if the patient is in group B, where is significant symptom burden without significant exacerbations, you can go for a LABA-LAMA combination, which unfortunately is not currently available in the Sri Lankan context without a steroid. We have to give it with a steroid if you want to give it. And then about this group B, it's a very important aspect that we have to talk about. Right? So the treatment goals of COPD is basically twofold: reduce symptoms, reduce the risk. What is the reducing of the risk? Reduce the risk of death. Reducing the risk of death and reduce the risk of progression, and by preventing exacerbations. That is, I think, the most important aspect that we have to go for. And for the patient, the most important thing is reduce symptoms. Whatever sophisticated treatment that we give, if we can't improve the patient's symptom burden, that treatment will not be effective. And these are the two what we call treatable traits that we have identified. One is the dyspnea treatable trait as well as the exacerbator treatable trait. So where we start with the LABA-LAMA, and then if the patient is not improving, especially we go according to the eosinophil count. Eosinophil count is a very important aspect in the investigation of a patient with COPD. 300 is the cutoff mark that we look at. In the patient who is having exacerbations in spite of the LABA-LAMA, that is group E, then if the eosinophil count is more than 300, that's the indication to add a steroid, not anything else. We have seen many patients who is on Beclate and Astalate with COPD, which has detrimental problems to the patient, including increasing pneumonia severity as well. So if the patient is having less than 300 eosinophils, and if the patient is exacerbating, what we have now is the phosphodiesterase inhibitor, roflumilast, or then we can go for azithromycin, especially in the patients who are previously smokers and when there's bronchiectasis, and the new drug is the dupilumab, which is not currently available in Sri Lanka. So other than pharmacotherapy, is it the only drugs that we have? No. According to the guidelines and everything, we have the smoking cessation for every group as well as the vaccinations. So in the Sri Lankan context, influenza vaccination is a must, and vaccination for pneumococcal vaccine. We have the conjugate 10 PCV10 followed by the PSSV 23. That is the current guideline. And RSV vaccination is very expensive, and probably we have to look at pertussis vaccination as well in these patients. And COPD is not an isolated disease. It has many comorbidities, especially patients will have high rates of diabetes, hypertension, and cardiovascular disease. So any patients should be managing with COPD should be managed as these comorbidities as well. I think all respiratory units and all OPD should have a blood pressure meter. LTOT and NRV is a new development, long-term oxygen, and we are fortunate that now oxygen is available in the government sector as well due to the work of our colleagues, especially Ravin in Colombo. And in patients who have long-standing hypoxemia, severe hypoxemia, that is resting oxygen level less than 55 millimeters mercury, there is an indication for long-term oxygen therapy in these patients, especially it prolongs life. But in moderate hypoxemia, there is no evidence to say that it prolongs life, especially in patients who are having a resting carbon dioxide of 53 millimeters mercury and patient coming with type 2 respiratory failure. There will be an indication for home NIV as well in certain groups of people that will prolong their symptomatology. So I'm on cue and on time. Last slide. So these patients will come to our hospital with these x-rays and with these this is what we call the coving of the lung function. And unfortunately, about 20 years back, we didn't have nothing to offer. But now, due to the developments in the COPD, especially even in Sri Lanka, where we have a resource poor setting, we can offer them much. And hopefully, we can send them with this typical Sri Lankan smile and home rather than somewhere else. Thank you very much.
I think now you had a very clear understanding and the basics of current status of the COPD. Listening to Neranjan Dissanayake, it was an excellent presentation and give us the recent knowledge as well as exactly what we should do the patients with so-called COPD coming to us. Now, the last few years, now when we were juniors, like a medical student and the registrar, even in the early part of our senior registrar time, now the COPD is a disease caused by smoking. That was what we knew and that we were just thinking. We never diagnosed COPD. We never write a diagnostic card of COPD in the female patient who admit to our units. That means the medical units when we were in the house officers as well as registrars in medicine. So that we never thought about the COPD can caused by any other causes. So that was the thing. So now the recent development the last several years, where Neranjan nicely mentioned the goal and the Arnold study, where I am one of member of those two study groups, and we found that several things related to COPD etiology, not only our research, but several other research. So the non-smoking COPD is another important area we need to emphasize. As you know, the COPD, actually, just mentioned, is a disease of the airway as well as lung parenchyma. Now, COPD is the third leading cause of death worldwide, causing roughly about 3.23 million deaths. This is a little old one, should be more than that, as mentioned. And 90% of the COPD death in those under 70 years of age occur in the so-called low and middle income country where we are living. So the low and middle income country, the COPD become a big problem, and is affecting the economy of the country as well as the health of the people. As well as COPD is the seventh leading cause of poor health worldwide. So that is another important. The COPD has so COPD is a growing. The incidence and the prevalence is growing, and compared to the other diseases, I will use that slide here, showing the World Health Organization COPD getting the increasing in number, prevalence as well as incidence. Now the tobacco smoking, as we all aware, account for over 70% of the COPD cases in the high-income countries, where are the affluent countries, because their environment is much better than us, and there are so many other things when you compare to the developed countries. They have a better environment, better economy, and better the pollution is concerned. But in the low and middle income country, the tobacco smoking, that is more, count for 30 to 40% of COPD cases. So what should be the rest thing? The rest should be the non-smoking COPD. And the household air pollution is the major risk factor. Now, as I mentioned, all the smoking is a major risk factor. It is now clear that tobacco smoking in adult life is not only the cause of the COPD. That's what I was mentioning. There are many other risk factors. Now, they just for two things, namely female sex. Although the females are more prone to develop this COPD compared to male in their genetic background. The age over 65 elderly naturally, and the exposure to indoor and outdoor person, poor lung growth will come a little later. So the various other causes they are recognized by the research, evidence-based. They are responsible for COPD. The prevalence in the non-smokers are very so that not necessarily I told the COPD to be appearing in the smokers. Not only smokers, but the non-smokers are there. Now, according to a particular study called Prevalence and Incidence of COPD in smoker and non-smoker, Rotterdam study in 2016, they have found that in ever smokers, 17.8% had a COPD, ever smoke. And the never smoker, the prevalence of COPD is 6.4%. Is almost a half of it. So in men, 17.3% in this particular study were never smokers, and compared to 46% never smoking women. So in other words, the female has a very high incidence of COPD in the never smoker group compared to smokers of male. So this Rotterdam study has shown clearly how the prevalence of the COPD in females is. And during 2013 and 2017, an estimated 2.4 million working adults, so that means the million working adults in the USA, about 18 years old, never smoked had COPD. So in the very huge number, even in USA, is not due to COPD, not due to so-called smoking. The highest COPD prevalent among the various occupations, like in information tech sector, as well as the mining industries, as well as office and administrative support occupation work. So these subgroup of population, that the different working group had a very high prevalence of COPD for this particular study. And among the workers who never smoke, the highest COPD prevalence was among women, as I mentioned in the previous study, and adult age is more than 65. So that's why we say that more common in the female and more common over the age of 65 years. Finding of high COPD prevalence among workers who never smoke collaborate finding that occupational exposure in addition to smoking might be associated with the development of COPD. Mahood et al. Study the prevalence and etiological profile of COPD in the non-smoker in 2017 that revealed that proportion of non-smoker individual among total COPD patients was found to be higher than smoker. So although we were talking a lot about smoking, but there are a very high percentage of non-smokers having COPD. These are evidence-based and proven. So what are those possible causes? One is the genetic factors. We have nicely mentioned the previous lectures, how the genomics and all involved at the genetic level. So genetic factors are very important. That's why not that all smokers are going to do the lung cancer or COPD. There are genetic background and mapping. They are more predisposing. The long-standing asthma. Now we never diagnosed the COPD in asthma. So now the chronic asthma is the cause for COPD. And environmental tobacco smoke. And outdoor air pollution. We are talking years now, last 30 years, how the environmental pollution, indoor and outdoor, are imposing the several lung diseases, including COPD. And the biomass smoke is a biggest culprit in the so-called third world countries, the Asia and Africa and South American countries, are the cause of lung diseases, not only COPD. Occupational exposure is the different occupation, including traffic officers. Recurrent respiratory infection in the early childhood. It's very, very important in Sri Lanka because in time to come, our pediatric patients, that the children who are exposed to recurrent lower respiratory infection every week, every month, due to the so-called preschool as well as kindergarten, they all end up with a COPD. Now, Neranjan nicely mentioned that the lung growth will maximize in 18 years in the female as well as 24 in the male. So that directly affecting the lung growth as well as COPD. So the recurrent respiratory infection in childhood, so one of the very, very important cause of not only COPD, many other lung diseases. That will be the problem. Time to come, we may not be here, but but that our junior consultant will face this crisis in time to come. The pulmonary tuberculosis, that is well known by us, and we have done also a lot of study on that, and the low socioeconomic status, female sex, as well as these are very important causes of COPD, non-smoking COPD. Now, what is occupation exposures? The multiple study were analyzed occupation exposure as a risk factor for development. It's a well-known one. The two studies carried in the United States found that the fraction of COPD attributed to the work in the never smokers of 31.1 and saw the increased risk of odds ratio, where the vapors, gases, dust, and fumes and with job exposure metrics. So very, very important occupation study. And Switzerland study has shown that the biological powders and the mineral powder, gas and vapor are important. Not only one country, even in the developed world like the US, Switzerland. Same with Sweden has shown that the gas, dust, and vapors are very, very important as a causative factor of COPD. And this particular study has shown that the high prevalence of COPD as well as a goal, more than severe goal status, are where the occupational stores are very, very important. The biomass poor, where we are facing a lot in the developing countries. The few studies were exclusively included women never smokers analyzed the effect of biomass as a risk factor for development of COPD. We call Daralipa in our society. Daralipa, it's in the Sri Lanka, in Asia, African, South American. Daralipa has become a common problem to biomass poor. That's why when the medical student come, every one of the medical students going through me had to write on the environmental pollution as well as the biomass poor when they do appointment with me. But they should know as a doctor, one day they are going to be a doctor. The Spanish study has concluded that combined use of wood and coal significantly raised the risk of COPD or ratio of 4.5. Study conducted in Turkey also are given a very huge number like 23.1. Mexico almost same. India and 54% of increase the risk of the p value of 0.001. Highly significant development of COPD biomass poor. And the Mahout study has shown that low socioeconomic group, naturally, the low socioeconomic groups are commonly used biomass poor, except that we have that poor crisis. Low economic group are the people who are using the biomass poor are more chance to get that developed. And the biomass smoke was a very high percentage of that. Not only that, they were associated with other risk factors like pulmonary TB and chronic asthma, also part of it. So these studies have clearly shown that how effective this are. Passive smoking is another important thing, whereas they are not active environmental tobacco smoke, like the passive smoking exposing adulthood and respiratory symptoms, and even children, where the Neranjan's research are nicely shown. And there's a dose-response relationship. How long you are exposing and how much you are exposing. At home, at work, if you have both exposure, home and work, your prevalence of incidence and the development of COPD will be double. I'm not just saying figures, are double than if you expose alone. Jordan studies that the increase in passive smoke exposure was independently associated with the increased risk of study. Same as the Huckstad study also found that COPD and exposed to passive smoking, the home and working has shown a very highly significant the prevalence of what we call COPD. This is showing that. And the asthma is another one. When you have chronic persistent asthma, uncontrolled asthma over the years with recurrent exacerbation, they will get several structural changes to the airways that will lead into the so-called COPD. That is the final stage of asthma. So it has shown the asthma is a risk factor for COPD. So that's why the chronic persistent asthma behave like a COPD. Now we can label them as a COPD. Their managements are completely different. So these particular studies have shown that Mahout done, where the long-standing asthma has shown that highly significant develop the COPD of a p-value of 0.003. What could be the possible underlying causes in how asthma becoming COPD? One of the persistent airway inflammation and the remote, which I have mentioned little earlier. Other one, the environmental exposures and trigger. When already having uncontrolled asthma with ongoing exposure to environmental pollutant is an adult risk factor, even in the non-smoker, can contribute to the airway damage as well as a respiratory symptom leading to so-called COPD. And age-related change and disease progression. When you progress the disease, when you become elder, all these things, if you are going to aging individual with asthma, may explain the decline in lung function that is related to COPD phenotypes. and potential misdiagnosis of overlapping features. Sometimes they can have both asthma and COPD. They are smoker and exposed pollution. They have both, but we diagnose as asthma. No, they are all overlap. Asthma COPD overlap. That's very important to recognize. Because our management will strategically depend on they are going asthma predominant type or COPD predominant. The managements are completely different. And the genetic factors, such as if you have asthma patient with genetic susceptibility, their genetic mapping is as such that they may develop the COPD on time goes on. And treatment-related factors, the prolonged use of certain asthma medication, particularly high-dose inhaled or oral corticosteroid, might predispose some with the COPD-like symptom of the development of COPD. So there are some effects, particularly short-acting bronchodilators. And exacerbation and anemia, when you have frequent exacerbation, naturally, you are going to liking the COPD exacerbation so important. Asthma exacerbation also leading to this patient to irreversible changes, airway remodeling, dynamic changes, and the parenchyma leading to so-called COPD. Another important is very important in our part of the world where the tuberculosis. Perez Federer et al. Is conducting a study in Latin America showed that previous diagnosis of tuberculosis was 3.6. I just want to remember that we have done a study sometime before. We have shown that how prevalence of COPD in patients who are treated for tuberculosis. It is not, so that's why when the patient completely for TB, they can go to asthma phenotype or COPD type, even both. So it's not uncommon. It's not uncommon. So these people, the day they start the COPD, we have to start as TB, we have to start the COPD treatment. Other they will come over and over with the breathlessness and cough and sputum production. Important. In the Korean studies, I shown that another finding, even in the Arnold study, actual Korean study, we are the members of that. I shown a very high prevalence of COPD in that group. And India again, 32.74% increases for COPD were reported in the subject with a history of tuberculosis. But that mycobacteria will change the airway, change the parenchyma, they completely remodel, even if it naturally look normal looking just like that, but that architecture is completely changed. The dynamics change, architecture change, structure change by the mycobacteria that is leading to so-called tuberculosis, COPD. In this particular Mahaudvan, they said treated pulmonary TB, it has a very high percentage and a very highly significant value, 0.001. Another study by the Peirce and Fadila again has shown the highly significant the underlying etiology in COPD. And the respiratory infection. I was talking to you a little earlier how respiratory infection are important in the respiratory disorder in chronic term. In not only COPD, ILDs are so many bronchitis, so many other lung conditions where that's our children are facing today, that crisis because of the air pollution, because of a so-called kindergarten, having school close to the main school, main roads. We are talking all the years, but nothing happening in this country. So we are almost given up. Talking about environmental pollution, all these things are no point at all. In Canada itself, having the GA told one, I think 32 schools or something. In Canada city itself, small and the bigger school. Almost all main schools are close to the main road. None is in the villages. No one will want to go to that village school. And we have shown, we have done a study, has shown this in subject called evidence-based, how common the respiratory disorders in children and the preschool children. And it is a crime that the children has to go to doctor every week or every month for treatment. The people who are having children will realize that. And unless they are living in a village or remote village, they are much better, they are healthy. So our children will time to come will have more COPD, more ILD. ILD, for example, is an epidemic. Interstitial lung disease is an epidemic. Every week we have few cases. Why? Because of this infection, nothing else. Nothing else. Okay. So the lung development and disturbs that I was talking myself and Neranjan, lung development definitely affect the children because of the so-called recurrent respiratory infection and the airway damage by infection and the pollution both together. And remember the PM2.5 are very high in the environment because of the air pollution. PM2.5 is a carrier for infection that leading to so-called recurrent infection. That's why you had a healthy life during COVID. Except COVID, other than that, you are fine. Except COVID, everything else is fine. Except the economy. And heightened vulnerability. Immune system, they completely alter the immune system. That's why children are not having resistance single organisms. Long-term effects of the air pollution as well as infection that I was explaining. And they started conducting Tunisia. has shown the threefold higher risk of developing COPD in these children and record the hospitalization due to childhood respiratory infection. They are clearly shown. And we have shown our studies also. I think I could never put that slide here. History of respiratory infection childhood is very, very important. This has shown in all the studies. So it is nothing to just what you call fabricated story. This is the truth. Genetic factors, I'm not going to alcohol and deficiencies. There is a well-known risk factor for COPD. Not only alcohol and there are protease inhibitor variants like SLP and neurofilm, lung development genes, the Neranjan Dissanayake, there are many lung development genes are in lung growth, repair and structure. Implemented response genes are there, interleukin IL-6 and IL-8 and TNA alpha and other cytokines. And oxidative stress and antioxidant, there are many, many genes are in all so-called development of COPD. Socioeconomic status. Now, intrauterine growth retardation, poor nutrition, that's a poor socioeconomic status, housing condition, childhood respiratory infection, exposure to tobacco smoke, the very poor, common in the very poor socioeconomic group, biomass smoke, and other indoor pollution. There's a lot of occupation inside their house and occupation. All are well associated with the development of COPD. The associated socioeconomic status common in our part of the world. And all collective contribute to the development of so-called COPD, not only impact, everything collectively act on this one. And the female sex, I don't know the main reason, maybe genetically, more frequently in the women and the older age groups. And that's shown clearly in Lampard study where how women is having more COPD prevalent compared to men, goal 1 and the severity also more. Age is very important. Getting more ages, increase significant associated with the high prevalence of COPD. It was highly significant. And older than smoking with the COPD. So they're very clearly associated. These are shown in the studies. Symptoms in non-smokers, nothing much, the same thing, same COPD, shortness of breath, cough, wheezing, just I'm not going to tell you, most of the doctors as well. And they are the typical symptoms of the COPD. And the sputum production, they have done a lot of study in this group, has shown the symptoms are almost same like smoking COPD. The never smoker COPD may have mild symptom compared to smoking, but it is a variable, but overall, a less symptom. The NAN study shows that never smoke experience the fewer symptom or mild form of the disease, less inflammation compared to smoke. Naturally, the smoking has more harm, but when you put everything together, that's important. The COPD, the never smoke have a different phenotype. So, but time to come, we'll get answer this. But there are some changes. I will come to the next slide. Now then, so-called ex-smoker who had a smoke 20 years before, now developing COPD. How that will affect the COPD, we may be able to find the details in the time to come, but that will be definitely a contributing factor, so-called ex-smoke. And what is important to know, this so-called never smoking COPD, they have a mainly the airway problems, significant changes of bronchitis and fibrosis increase eosinophilic components. And anthracosis, that means the carbon particle deposit on the airway, causing the fibrosis and leading thickening of the airway walls and vascular endothelium. So the non-smoking COPD has a distinct radiological involvement and the pathological compared to smoking. Okay, so it is a different phenotypes. And the Mexican study has shown that similar clinical characteristics, quality of life and mortality to those with COPD tuberculosis. So even mortality concern when together, I told this is a combination all and some studies have shown some more lung fibrosis, but usually non-smoking COPD is mainly airway diseases like chronic bronchitis type, but they also will have some effect on parenchyma, the greater pigment deposition and the thick pulmonary artery. So they may develop the pulmonary hypertension more commonly than the other one. So it has shown that when the sex with this group, male and female, the male smoker have a decreased survival compared to female in this group. So female has a better survival than the male. Now our neighbors, Sandeep, one of our good friends, his study in the non-smoking series has concluded that smoking COPD and non-smoking COPD is seen in the younger subject. The non-smoking COPD is in the younger subject with the equal male-female predominant is predominantly the small airway disease phenotype with a less emphysema, preserved lung diffusion, slower rate of decline in lung function. So in our neighbors, India studied, Salvi has done a lot of study on this. shown that this is mainly the airway disease. Lung function deteriorates gradually versus less than the smoking one. More young people and the male and female, the similar predisposition. So the similar predisposition, the similar prevalence. How do you diagnose? Same way of diagnosis, the history and examination. I'm not going to tell these things. What is important is digging into the history, find out the causative factor, biomass or otherwise. So the medical history is very, very important, respiratory symptoms and pollution and etc. Lung function is a little, non-smoking is a little better than the smokers, right? Because the parenchymal damage is a little less compared to the so-called non-smoking COPD. So I had shown that airways are more damaged than parenchyma, so that has shown the more reduced ratio than that means smoker COPD has a more involved airways than the non-smoking COPD. So remember, the smoking COPD happened to both parenchyma as airways, but the non-smoking main, that is what is called airways are there, but lung function has a worse in the smoking group compared to non-smoking. Imaging study, I told you the normal COPD features of COPD, parenchyma as airways, but this so-called non-smoking COPD means the airway, not the airway thickening, so we call it dirty lung. That means it's a more prominent bronchoscopy marking compared to the MPC, but it changes. So the CT we can give us more feature, but more on airway normal than the so the emphysema is less because chronic bronchitis is more. And our studies, you can do in Sri Lanka, where the Dr. Keitha Gunasekara, this is the main researcher in that one, I found that a significant proportion of Sri Lankan COPD patients were never smokers, exposed to dust environment, that you have pollution, firewood use, residing in the urban areas, low education, being older or female, increase the risk of COPD in never smoker, but not simple. So in our country, we have shown evidence, our details are almost same, the same like other never smoke, other part of the world, other part of the country, where the so-called non-smoking COPD. And our Arnold study also almost same. I'm not going to show that we have different phenotype according to like a genetic on COPD G or COPD abnormal lung function development D, and the environmental smoking for C, biomass of the pollution for COPD. These are different phenotypes. So these are, I think Neranjan mentioned that. Management is not big difference, almost same what the previous speaker mentioned, the same management. So all the basic managements are mandatory for COPD. And Neranjan explained clearly, and then Sachin told, COPD management is completely different from asthma management. Don't manage COPD like what you manage asthma. Completely different. And this is where the Neranjan nice explained, so I'm not going to explain that. And this is categorize them according to the lung function. What is important to understand, lung function alone cannot decide the COPD status. You need a number of exacerbation, the medical research council business care, and COPD assessment test, CAT score, putting everything together, we get A, B, and E. Early A, B, and C, and D now. C and D becoming E now. 100% management depend on that. So unfortunately, we have some restriction in our country. We do not have a combination of LAMA, LAMA. So we have big problem. Like or not, we have to add the little dose of steroid, even a minimal dose. That's the biggest problem we have in our country. So here, like asthma, review, assess, and adjust. Asthma, remember that GINA guideline when the students and registrars going to us, we nicely explain them how that depend on this. So the conclusion. Now our doctor's knowledge should be good with the so-called non-smoking. The lack of knowledge is the biggest problem, not only the COPD for everything else. High heterogeneity, like in we see the medical, I'm doing the medical work down in Kurunagala as a opinion, where my two registrars also here now. And we see that most of the patients hyponatremia coming SID on a CT of 25 BD. Having diagnosed it 1, 2, 3, 4, all are but still on a CT 25 BD. Unfortunately, the polypharmacy are the biggest problem the doctor's knowledge in this country. And COPD patient ETU given 100% oxygen sending to world, 100% oxygen. My two registrars also here, my parents, medical registrars. So we have seen this. It become a crisis in this country. as I'm a senior consultant, I'm almost 30 years, so I can tell without any afraid. So the trend on the decline of lung function is very important, and analyze implemented biomarkers. And we have to go to multi-center, have a big study coming up, what we call 34, and we will get more information time to come. Okay, if there's any question, I'm able to answer you.
Talking about the asthma GINA guidelines, which is just updated recently. And as you know, asthma is a very important entity which we see day in and day out in our practice. And all doctors see this, whether you are a surgeon or a VOG or any specialty, will see patients with asthma. So if you look at asthma, it's a very heterogeneous disease which is characterized by chronic airway inflammation, and you get these typical symptoms of wheezing, shortness of breath, chest tightness, and cough, which vary over time, and the intensity also varies over time with variable airway limitation. Some studies done in Sri Lanka. Dr. Kirti Gunasekara, our senior consultant respiratory physician, and his team showed this study where the prevalence of current wheezing was about 23.9%. This is just wheezing, not only asthma. And we also have self-reported asthma recorded as 11.8%, and correspondingly, current asthma medication use was around the same percentage. But thinking from these lines, probably our prevalence is somewhere in between 11.8 and 23.9%, so which is quite a high incidence and prevalence. So prevalence was higher in adults who are more than 44 years of age, with a percentage of 31.4% in this study. So it is quite a big problem in Sri Lanka. And looking at asthma, again, like in COPD, we are now recognizing more and more phenotypes in asthma. We'll be talking about this in other lectures as well, which is important in management of asthma. Of course, the typical allergic asthma is the most common, the typical asthma we have been talking about, which starts in childhood and is associated with past history or family history of atopy. And these patients also have may have associated eczema, allergic rhinitis, food or drug allergies, and their inflammation. If you look at their inflammation, it is mainly eosinophilic inflammation. And these are the patients who respond to steroids, typical asthmatic population. But of course, we now have seen many patients who are non-allergic asthmatics, where their inflammation can be varied. It can be a neutrophilic, eosinophilic, or postgranular inflammation. And they also have the main problem is they don't behave as the typical asthmatic. They have a poor response to steroids. Then we also have patients coming in who have never had any asthma in the past, in childhood, but present in adult or late onset asthmatics. This is more in females. They don't sometimes give a history of allergy in the past. And these patients often require high doses of steroids or have poor response to steroid. In this group, of course, we need to always exclude occupational asthma, as was talked in COPD. Most of the occupational exposures or even house dust and pollution are major causes of asthma exacerbations. Also, we now, as Professor Madegedara mentioned, we were seeing lots of non-smoking patients coming with asthma-like symptoms, but they behaved like a COPD patient. And these asthmatics are now classified under asthma with a persistent airway limitation. They behave like COPD, and they have airway remodeling. Obesity and asthma is another group which gives problems in management. These patients have little inflammation but lots of symptoms. So, and this is another group which we need to focus on. So, the main symptoms, as I said earlier, is wheeze, shortness of breath, chest tightness, and cough. Some patients may even present with only cough, no shortness of breath or wheezing. And the main characteristics of this is that the symptoms occur variably over time and vary in intensity. As opposed to COPD, these patients are often worse at night and on waking, while the COPD patients typically present with shortness of breath on exertion. These symptoms are often triggered by exercise, laughter, allergens, and cold air. And what you need to know, these are actually triggers, not allergies. So these are the triggers which bring about asthma. And if you treat asthma well, these can be mitigated. Symptoms worsen with exercise, and some patients will come to you and say, I only get this difficulty breathing while exercising. You have to differentiate between exercise-induced asthma, which is a very rare entity, very small group of patients. The majority of them are actually asthmatics who present or they feel breathless only when they exercise. But actually, if you go back into the history, you will find that these people are actually asthmatics. And of course, there are many patients who present and say, I only get these sort of symptoms only when I get a viral infection. So, and which is quite common these days, need to go into the history, and many of them probably are asthmatics. Diagnosis confirmation we can do with bronchodilator testing, give them a bronchodilator. And if you want getting better of more than 12% or more than 200 ml, you can have this confirmation. Of course, now lots of biomarkers in asthma are being investigated, especially elevated FeNO, nitric oxide in exhaled breath, which is a simple test to be done. Although we don't have it here in Kandy, it is quite widely used in other centers. And with this, you may get some evidence which may give evidence of asthma. And of course, as in COPD, eosinophilia, blood eosinophilia is also a surrogate marker of asthma. So, looking at the GINA guidelines, as shown here, I don't know whether you can see it at the back. When you get a patient with these symptoms, always think of asthma. Go into a detailed history and examination. Most of the time, when you see the patient, maybe the examination is completely normal. You may not hear any wheezing, but the history is vital to make the diagnosis of asthma. And once right, I think you can see my pointer. So if this is negative, then of course you need to look for other causes. But if the history is very suggestive, ideally you should do a spirometry or a peak flow at that point before you start them on treatment. But if that is not available, then you may consider doing the serum, the blood eosinophilia, and then you can give them A course of inhaled corticosteroids plus or minus bronchodilators depending on the severity, and review them in 3 months' time. At this point, you may again do a spirometry if it was not available previously, and then of course you can make a diagnosis of asthma or otherwise. Of course, if the spirometry is available at the initial stage, do a spirometry, confirm the diagnosis, and start them on treatment. So this is basically what is advised, the way you diagnose asthma. So as I said earlier, typical symptoms, typical history, airflow limitation, if you can demonstrate it, is one of the major ways you're going to do this. Of course, the role of FeNO and blood eosinophils is something which we need to think about. So eosinophilia, if you do a full blood count and see the white count, sometimes, unfortunately, in some of our OPDs, they don't have the 5-point analyzer, so the eosinophil count does not come into the picture in the report. But in many of the newer full blood counts, you will see the eosinophil count, as was talked about earlier in COPD, as well as in asthma. In both of these, eosinophil count is an important test which we do not only in the diagnosis but also in the management of these conditions. So clinical utility, it is useful in the diagnosis of asthma, phenotyping the asthma, and in the prognosis and risk of exacerbations. I will talk about them a little bit later. So phenotyping in patients with confirmed diagnosis of asthma, if the blood eosinophil count is at the upper limit of normal or more than that, it is considered and consistent with eosinophilic asthma. And if you do the FeNO, if it is more than 50 parts per billion in patients who have not had inhaled corticosteroids, or in patients with a medium dose inhaled corticosteroid, if it is more than 25, or in patients with a higher dose inhaled corticosteroid, if it's more than 20, it is consistent with eosinophilic asthma. So the treatment modality is then, of course, the steroids are the more important treatment modality. Then prognosis-wise, this is associated with exacerbations. So in inhaled corticosteroid-treated patients with a history of more than one or more exacerbations in the previous year, high eosinophilic counts or high FeNO are associated with a higher risk of exacerbation. If both are high, then there is a higher risk. Other tests, other features, of course, are associated with severe exacerbations, like including a past exacerbation history, poor symptom control, low lung function, a smoking history or pollution history, allergic rhinitis, and in these patients, they may have a higher risk of getting exacerbations. So clinical, these biomarkers are also useful in predicting the response to treatment. AIR is, or the MART regime. I will just talk about them a little bit later, but where we are using the inflammatory markers for treatment as and when needed. So that is where we are using inhaled corticosteroid with a bronchodilator as and when needed in mild asthmatics, or we are using continuous treatment, which is the MART regime. I will speak about them a little bit later, as opposed to a short-acting beta agonist reliever in patients with patients who are having high or low eosinophilia or FeNO has been shown to be useful. If the FeNO is high and your asthma is still not controlled, then despite having high-dose inhaled corticosteroids. Of course, always we need to check whether they are taking the inhaler, if they are compliant on taking the inhaler properly, or if their technique is good. And before we increase the dose of inhaled corticosteroid. If both the eosinophilia and FeNO are low, we may have to consider other treatment options before increasing inhaled corticosteroids. So these are some of the things which we need to think of, especially in these patients. So looking at the eosinophil count and the FeNO are useful in the management. So what are the goals of treatment of asthma? So basically, it is that you want to get these asthma patients back to normal, complete normalcy. So long-term asthma symptom control, no or very few symptoms, no disturbed sleep, unimpaired physical activity. You should be able to go to the Olympics and win the gold medal, right? So that is the thing which we need to give to our patients. Long term, there should be no risk, lower risk of exacerbations. There should be stable or improved lung function, no use of oral corticosteroids, and no medication adverse effects. So when discussing the best possible outcomes with the individual patient, we need to consider their clinical features, their asthma phenotype. Of course, many of these patients may have multiple other morbidities. We need to consider those, take those into consideration. And risk factors are, of course, poor adherence to the treatment, smoking, and persistent airway limitation. Of course, in asthma treatment, availability and the cost may have a role, may have serious implications in the management of these patients, especially in our setup, where sometimes we have available one type of inhaler at one time, and in the next month we have another type of inhaler being available. Sometimes we don't have inhalers available in our government setup. So those all have implications in the management of asthma. So always, in addition to that, we need to think about what are the goals the patient has for himself or herself. And that is very important. So health education, discussion with the patient about the patient's asthma management is, I think, a very important part of asthma management. Not just giving the medication and say, this is your medication, take it, you'll be all right. So risk for asthma exacerbations, again, a very important entity. One of our main goals is to prevent exacerbations. Uncontrolled asthma symptoms increase the risk of exacerbations. So even patients who are having very few symptoms, repeated use of short-acting beta agonists, that is what we use, is either, most of the time it's salbutamol. Sometimes some patients use ipratropium. But if you are using 3 or more canisters of salbutamol in the 12 months, it's shown that you are at higher risk of exacerbations. Now, in our setup, I think if we look at our statistics, we will find that we are doing lorry loads of salbutamol inhalers to our patients. Of course, that is because mainly that we have the combination of inhaled corticosteroid with salmeterol and the reliever being salbutamol. And in our setup, we just prescribe lorry loads of salbutamol. So we need to be very sure that the patients are using less of the salbutamol and more of the other inhaler, the inhaled corticosteroid. Also, inadequate inhaled corticosteroid use by either the patient or which have not been prescribed or incorrect inhaler technique is another important entity which we need to always think about. Comorbidities like obesity, chronic rhinosinusitis, gastroesophageal reflux disease, and confirmed food allergies and pregnancy are some of the other risk factors for exacerbations. Again, exposure to smoking, vaping, air pollution, allergen exposure is very important to be thought about and should be always checked for. Psychosocial and socioeconomic problems can have an impact. Some patients say just before the exam they get an asthma attack. So stress also has a part in exacerbations. Low lung function, high blood eosinophils, as I talked about, and past history of severe exacerbations are other risk factors. So that is with regard to exacerbations. Now, if you have very mild asthma, most of the time these patients may not even take continuous treatment. But it has been shown very clearly that 30 to 37% of adults with acute asthma and 16% of patients with near fatal asthma and 15 to 27% of adults dying of asthma have had very mild asthma and have actually had no symptoms in the previous 3 months. So this is an entity which we need to concentrate on and sometimes is neglected. Low-dose inhaled corticosteroids is extremely effective, but in studies done all over the world, it has been shown that adherence in the community is 25 to 50%, especially in the mild asthmatics, where many patients do not take, they think I'm all right, I will get an attack only when I get an infection or something like that. And therefore, they don't use the continuous use of inhaled corticosteroids, leading to a possible exacerbation. So, in these mild asthmatics, it's been shown that, previously in our guidelines before 2019, we gave them inhale short-acting beta agonist, the salbutamol inhaler, to use whenever they feel that they have symptoms. But it has been shown that now, as I showed earlier, this problem is these patients can have exacerbations, can die of asthma, and also use of short-acting beta agonist also is a major problem because the patient feels that he's better on that and seems to use more and more of salbutamol rather than the inhaled corticosteroid. So that's another problem. So that's why in the newer guidelines, you have 2 tracks of management. One, the more preferred track is track 1, where use of inhaled corticosteroid with formoterol is the preferred option. And in the steps 1 and 2, in the mild asthmatics, you can use this as and when needed, the inhaled corticosteroid with long-acting beta agonist formoterol, and still you can get very good control. And as you get worse and worse, you can add on the inhaled corticosteroids with higher doses. And of course, in step 4, which we'll be talking about in a little while, the next lecture, we will have how to manage these severe asthmatics. Unfortunately, in our setup, in the hospital setup, what we don't have the inhaled corticosteroid formoterol combination, but our college has done a lot of work during Dr. Neranjan's last year of presidency, trying to get this into our formulary, and I hope it will come into our system very soon. So at the moment, what we have in the hospital setup is the inhaled corticosteroid long-acting beta agonist combination and we are using the salbutamol inhaler as the reliever whenever they get an exacerbation. So the new words which are coming in with these new guidelines is AIR, which is as needed only inhaled corticosteroid formoterol combination in these steps 1 and 2, and MART stands for maintenance and reliever therapy, where you are using the same inhaler for maintenance of the asthma control, and the reliever, you use the same inhaler, which is the inhaled corticosteroid formoterol combination. So there's a lot of evidence to say that this is useful, and it has been shown very clearly in many studies that it reduces the mortality, reduces exacerbations, reduces hospitalizations, and the patient is much better, leads a better life with use of this combination. In children 6 to 11 years, the guidelines have not changed very much. You have the low-dose inhaled corticosteroid taken along with the short-acting beta agonist when needed, and you increase the dose. And if you come to step 4, you have addition of long-acting beta agonists like formoterol into this combination, and in some cases, you may add on tiotropium. So the guideline for starting treatment in a newly diagnosed patient, if you have daily symptoms or waking at night once a week or more, then you go to a moderate dose of inhaled corticosteroid with bronchodilator, or the track 2 again similarly. But if you have symptoms for less than 3 to 5 days per week with no nighttime symptoms, then you can give them inhaled corticosteroid with formoterol as and when needed. So that is a very important change in the management, which we have seen since in the guidelines since 2019, and this is the more preferred option. So assessment of asthma. There are 2 components to this. When you see the patient coming to you for assessment, recent asthma symptom control should be assessed. And then, of course, if there are any exacerbation, if there is persistent airway limitation, and medication side effects should be looked for in these patients. And the 4 simple questions you ask these patients are: daytime asthma symptoms more than twice a week, any nighttime awakening due to asthma, or use of short-acting beta agonists, reliever for symptoms more than twice a week, or any activity limitation. And if these all 4 questions are no, then you are well controlled. If you answer yes to 1 or 2 of these questions, then it is partly controlled. And of course, if you are answering yes to 3 or 4 of these questions, then you are uncontrolled. You need to step up on your management, see what the problem is. So short-acting beta use, as I said earlier, as I think I have done this slide, so I'll go for the next slide. Again, as Professor Madegedara and Neranjan said, extreme weather and asthma is also associated, and it's given pride of place in the new guidelines. Extreme cold spells, extreme heat, which we see on and off now in our setup in Sri Lanka as well, and in many other countries, can lead to asthma attacks. And then in other countries, they have a pollen count coming in with the weather report, which can exacerbate asthma. Always, when patients are not controlled, always look at their compliance and their inhaler technique, because that is one of the major problems in poor asthma control. So that is something I think we need to always look at. It's not only just giving the medication. Are the patients taking the medication properly, and is their technique correct? Because it is not as easy as drinking a tablet. So in conclusion, asthma management, main thing is to get the diagnosis correct, treat appropriately, assess, adjust, and review. And as I said earlier, as I showed, as opposed to COPD, inhaled corticosteroids is the mainstay of management in this and aim for good asthma control. Thank you very much.
So I'll be talking about CV asthma. And once again, thanks for the organizers for this opportunity. So what is asthma? Now you all know what is asthma. It is a chronic. You look at these pictures alone, you will know it is chronic. Yeah. So it is a chronic airway inflammation with variable symptoms like wheezing, short of breath, and chest tightness. Pathophysiologically with reversible airflow obstruction, and also there are a lot of triggers that is triggering the asthma symptoms. So that is basically the definition of asthma. But what is interesting is they have also added this term heterogeneous disease, which has been mentioned and highlighted by all the three speakers before me in the terms of asthma phenotypes and COPD phenotypes. That is the heterogeneity that we are talking about. So asthma and also COPD, it's not one disease. So different to the that understanding that we had maybe several years back, we thought it's one disease, asthma, COPD. But no, it's not. It's a range. It's a spectrum of disease, and there are a lot of phenotypes. So that is very important message that from all these lecture series. So I'm going to talk about the severe asthma. So asthma severity, the symptomatic asthma severity can be assessed using the daytime and nighttime symptoms. If the daytime symptoms are continuous, like almost every day per week, and of course the nocturnal symptoms are more than at least 2 per week, 2 or more nocturnal night symptoms, which disturbs the night. So that is severe asthma. Also, they would have lung functions with FEV1 less than 60% predicted, and also if you look at the diurnal variation of the peak flow, that will also be very high. So that is severe asthma. However, all these patients with severe asthma symptoms, do they really have true severe asthma? No. Majority, as discussed in the previous lecture, are difficult patients. They don't take treatment. It is very well known that if your symptoms are less than twice per week, you would not take your treatment regularly. So the compliance is very poor. So when I see my patients, the hospital and even in the private sector, one of my goals is to at least make one patient per day to make sure that patient is compliant with their inhalers. So I ask them, they are on diabetic medicine, hypertensive medicine, asthma medicine. I ask, okay, you take asthma when and only when you need asthma medicine. What about your sugar treatment, blood pressure treatment? Do you all take it like that? Only haphazardly? No. They don't know because their blood pressure goes up, blood sugar goes up. They don't feel that. So patients take asthma, other medicine. But when it comes to asthma, everybody is a physician because they think that when you feel, you can take medicine, but if you don't feel, you can just stop it, which is a very wrong concept. So that you have to educate your patients. So there are a lot of difficult patients, or like patients who are not taking treatment. Then there are another set of patients who are having multiple comorbidities and also problems with their techniques, inhaler techniques. So once you correct the inhaler techniques, majority of them, again, they have a very good asthma control. And also when you treat the comorbidities like reflux disease, gastroesophageal reflux, or maybe allergic rhinitis, again, then the asthma improves. So, however, even after you treat all these comorbidities and the other conditions, still you are having severe asthma symptoms, then you are having a true severe asthma patient. So that, of course, would come up to around 4% of that total asthma population. So not all severe symptomatic asthma patients are true severe asthmatics. However, there are severe asthmatics, which is defined as uncontrolled asthma despite maximum optimized in the sense that they get good doses, the adequate doses, and also with proper techniques, optimized treatment, and also after the treatment of contributory factors and the comorbidities, still if the asthma symptoms are severe, that is severe asthma. So more practically, that is if you are still not controlled, or if you are dependent on high dose inhaled corticosteroids for adequate asthma control, or if you are getting uncontrolled when you try to tail off your high dose steroids, then again It's a more practical definition of severe asthma. So what is this asthma control, which was mentioned earlier? So it's a very simple, practical set of questions. You ask about your symptoms, how are you, whether the asthma affects your daytime functions, whether are you breathlessness, whether do you have a good sleep, and I'm sorry about the small font, whether, here they ask about how frequently you use your reliever, the salbutamol. So likewise, so it has been mentioned earlier. So this is a very simple test, that is asthma control test. And also, what is about these high dose inhaled corticosteroids? Now we know there are a lot of inhaled corticosteroids. The common things would be beclomethasone and budesonide, and also we have fluticasone. When it comes to asthma, as mentioned by Dr. Manil Peiris, the formoterol based, we'll come to that in a while. So about the steroids, beclomethasone and budesonide, the high dose would be around 1000. If you can see here, it's around 1000 per day. So for example, if the beclomethasone, which comes in 250 or maybe 200, if you take 4 puff per day, that is 250, 2 puff morning, 2 puff evening, that would be a high dose of steroids. When it comes to fluticasone, which comes in 250, even 1 puff twice a day would be 500. Sometimes you take it as 1000 again. So that is the high dose of inhaled corticosteroids. So because of the bioavailability and also the particulate size of the steroids, there are different cutoffs for different steroids. So we have to know these equivalent doses when you are prescribing. And also there are other finer particles like beclomethasone ultrafine, small particles which have better lung penetration and they have better access to the distant airways or the small airways. So they only need a smaller dose of per day to make it high dose. Even cyclosanide here, there are small particles, they need about 320, so that would be considered at high dose. So there are differences depending on the steroid that we are talking about. So once again, about the severe asthma, so they have frequent daytime and nighttime symptoms. They will have frequent exacerbations because the asthma is not controlled, which is taken as 2 or more exacerbations per day, per year, per 12 months. And also they will be dependent on high dose steroids, and they will be using a lot of relievers like salbutamol for their asthma control. So that is again severe asthma. Additionally, they would have a lot of comorbidities like rhinosinusitis, gastroesophageal reflux disease, and also obesity, obstructive sleep apnea, and not only that, anxiety and depression. So all these things should be properly assessed and controlled before you labeling a patient as a severe asthmatic, because these all contribute to the patient's symptom burden. The new thing is that once we have this severe asthmatic patients, once you have once you have excluded these other possibilities, now you have to assess their phenotype or their biological biomarkers. So that is basically we use the peripheral blood eosinophil counts. Then also we can use the sputum eosinophil counts, and also FeNO. FeNO is the nitric oxide in the exhaled breath. We'll talk about that in a bit, and also IgE levels. So when you're talking about these biomarkers, we come to this famous picture, that is the asthma pathophysiology. So the bottom line is here the smooth muscle cell with the smooth muscle contraction. So that is what happened at the end. Bronchoconstriction, smooth muscle contraction. Now you can see here, up to here, that is eosinophilic inflammation. This part is eosinophilic inflammation, right? This part is non-eosinophilic inflammation. That is neutrophils are here. It's a neutrophilic inflammation. So even this eosinophilic inflammation, you can see there are different pathways. There's an allergen. This is the allergenic pathways, which is the T helper 2 pathway. So that's the basic, the most commonest immunomodulatory pathway in asthma. That's the T helper 2 pathway. But here also this eosinophilic inflammation, but this is a different pathway. It's a non-allergenic pathway. Now you can see here it is non-allergenic, but still it would end up in eosinophilic inflammation. However, there are certain other non-allergenics which will go in a different pathway, which is a neutrophilic inflammation pathway. So the cytokines, the mediators, everything is different. Now you can see here This is T helper 2, and there are interleukin 4, 5, 13, which are the very famous interleukins that we'll be talking about again when we come to the treatment. And this is the T helper 2 cell, and which makes the B cell, that's a plasma cell, into a mast cell. So the plasma cell are triggered to produce IgE antibodies. That is the whole marker of eosinophilic inflammation, IgE antibodies. That is type 1 allergic responses. Then, of course, this is the eosinophils to IL-5 and IL-13. Here, of course, this is non-allergic eosinophilic pathway. You don't have IgE levels. So, likewise, there are a lot of differences. So, this understanding is very important when it comes to the treatment. So, what is this nitric oxide? Again, from the inflamed airways, they produce nitric oxide in response to IL-4 and IL-13. So if your interleukin 4 and 13 levels are elevated, it is postulated that your nitric oxide levels are also elevated, and you can measure the nitric oxide levels that come in the exhaled air. It's a very simple test using this very simple machine. You can just ask them to blow out, and then there will be the figure that comes, which was mentioned earlier by Dr. Manil Peiris. And if your nitric oxide levels, and you have to interpret it according to your steroid use, as mentioned earlier. So these are now a few of the newer things that we do, and these things are available also. So this is your airway. You can see this is the epithelium and the interstitium, the cells, the smooth muscles, and beyond that, now this is the blood vessel, and this is the lumen of the airways. So now there is inflammation, and into the lumen comes the eosinophil. Some of the eosinophils are released to the lumen, and also the nitric oxide is released. So you can check the exhaled air or the sputum for eosinophil counts and the nitric oxides. And in the blood, there's a lot of eosinophils, so you can check the blood eosinophil counts, and also IgE levels you can check. Likewise, you can check these different biomarkers to assess the asthma phenotypes, which is very important when it comes to the precision medicine. Now, as we are talking about this targeted therapy, the precision treatment, when we come to that level, it is very important that we have a basic understanding about their primary pathophysiology. The same picture now, we mentioned that in severe asthma also, that is mostly type 2 inhalation, type 2 inflammation, Th2 inflammation, which is the classical allergic pathway with IL-4, 5, and 13. But however, there's another group with low type 2 inflammation, as mentioned in the previous lecture. There are different phenotypes, so we'll talk about that as well. So there are shared features with mild and moderate asthma. Basically, there's airway inflammation, bronchial hyperresponsiveness, reversible airflow limitation, and the type 2 inflammation, inflammation, eosinophilic inflammation. So these are all shared with mild, moderate, and severe asthma. However, in severe asthma, in addition to these things, you will also get persistent and uncontrolled inflammation because it's a severe disease. So you get persistent inflammation. And also they are more steroid resistant because they have also some sort of a bit of neutrophilic and non-eosinophilic inflammation also there. The component is there. And they have severe airway remodeling, which manifests as the lung functions, which is not fully reversible. They can be partially reversible. Sometimes in severe cases, they are non-reversible at all. So that is where you go into chronic phase of asthma, which is very difficult to manage. So there are different phenotypes or the clinical severities, and these patients will have these features. And their immune pathways are obviously altered, as mentioned earlier. They have more mucus plugging and more comorbidities. Okay. Yeah, so asthma phenotypes. So the term phenotypes come again and again. So now I think it's very clear to all of you that we are talking not about a single disease entity. It's a spectrum, and we have to identify the different treatable traits in each of these diseases. So these traits or the phenotypes helps us to guide the personal treatment, and also we can predict the patient's clinical response and the disease progression. If you are in a one phenotype, obesity, asthma, we know that okay, this is your progression. Your allergic asthma, okay, this is your progression. We can predict, and also the treatment response, and it's important in treating the treatment. Now this is again one of the slides which is in common use when we talk about asthma phenotypes. Some of these have been mentioned earlier: allergic asthma versus non-allergic asthma. late onset versus early onset asthma, eosinophilic versus non-eosinophilic or neutrophilic asthma, obesity-associated asthma, exercise-induced asthma, and aspirin-sensitive asthma. So there are different phenotypes. Now here, if you look at it, this is early onset versus late onset. This is about the severity. This is about the genetic background and also the lung functions. So some of these asthma, they are early onset. Now, for example, exercise-induced asthma, allergic asthma, and some of the infection-related asthma can be early onset, whereas neutrophilic and the obesity-associated, and they are late onset. If you talk about the severity, if you take this half, allergic and eosinophilic, neutrophilic asthma, and also low Th2 asthma, they can be very symptomatic and very severe. Whereas exercise-induced asthma and infection-related and some of the allergic asthma can be less severe. So likewise, there are different phenotypes that helps you to predict. The management of asthma again was nicely explained earlier. So the goals of treatment is 1, to control symptoms, and 2, to prevent exacerbations, and then to maintain near normal activity. Dr. Manil Peiris said that they should be able to go to Olympics. Yes, that is the level of care that we expect, and maintain normal lung functions and minimize the side effects of the medicine. So again, the stepwise approach has been explained earlier, so I cannot overemphasize the importance of this figure. Again, there are 2 pathways or 2 tracks as mentioned. One is the preferred pathway where you are talking about now mostly steroids with formoterol. So ICS, that is ICS LABA, broncho beta agonist. Beta agonist, we have mainly salmeterol and formoterol. I'm sure that most of you are aware that formoterol is preferred because it has been observed that they have more rapid onset of action. So they can be taken as a reliever as well. So then you don't need a salbutamol. Otherwise, what happens is patients become more used to salbutamol and they stop taking the ICS LABA or the combined inhaler and they only take the salbutamol. So to prevent that, if you only have one inhaler, they have to anyway use that. So ICS formoterol, but only problem is we don't have it in the government sector, even though it's there in the private sector. But again, if we can still use ICS salmeterol, but then of course we have to use the salbutamol inhaler for the reliever. So likewise, there are few changes that we can do. But for the severe asthma, we are talking about this step 5, which mentions about the additional of long-acting muscarinics, that's the tiotropium, or we are talking about the phenotype based precision treatment, including the biologics and also high dose inhaled steroids and oral steroids. Likewise, the last step of the management of asthma, which I'll be talking in the next few slides. And also there are a lot of other non-pharmacological things that again, allergen avoidance and smoking cessation, because cigarette smoking in an asthmatic who has a eosinophilic inflammation can shift the cell type to neutrophilic inflammation. So they become non-eosinophilic with the cigarette smoking, and that's becomes difficult to treat. So likewise, so you have to address all these non-pharmacological approaches as well. Right. So come to the treatment. What are the treatment options we have for severe asthma? High dose maintenance ICS LABA, basically high dose inhaled corticosteroids, which sometimes you might not be able to continue long term because there are side effects. Obviously, there can be systemic absorption. However, at least for a short term, you might have to use that. So high dose inhaled corticosteroids with combined inhalers. Long-acting muscarinic antagonist, that's a tiotropium we are having, so we can add on to the other combined. So we can go for triple therapy for asthma, which is tiotropium is mainly for the COPD, but then of course for severe asthmatics we can add it. Then there's a place for oral and systemic maintenance steroids, again at the expense of side effects. Then of course macrolides, that is azithromycin, for their immunomodulatory action we can use. There are evidence for that. Especially for non-eosinophilic asthma, which is steroid resistant. One important thing is we have to exclude other non-tuberculous mycobacteria infections if you are going to start long-term azithromycin, because that is one of the treatment for NTM. Then ultimately we come to the biologics, which is the future of asthma. When we say future, it is future for us, but it has been decades now. Other countries are using biologics, so we are far behind in that. However, hopefully we are progressing. So what about these high dose inhaled corticosteroids and combined inhalers? So we have different options. Symbicort, Foracort. So these are formoterol based, because as we mentioned earlier, formoterol has a rapid onset and can be used as reliever as well. So it is preferred. But also what is available in the government sector is the salmeterol combination, fluticasone salmeterol. The Frisoflow is one trade name. So we have all these inhalers. Fostea is not available to us. That has beclomethasone extra fine particles. So that is very good for small airway disease, because the penetration is better. But it is unfortunately we don't have it. We had the cyclosonide earlier, which again has a similar property, again which is not available at the moment. Then there are triple inhalers. Again, we don't have these things. So if you take these budesonide based inhalers, so we need about 1,000 mics per day. So we, at least sometimes we take 2 puff morning, 2 puff evening. So that's quite a high dose. So patients, at least temporarily or a short term, they have to be on high doses. So that's about the typical high doses for inhaled corticosteroids. Then we'll come to the biologics. So we are talking now. The biologics are already in use for other conditions like rheumatological conditions, malignancies, inflammatory bowel diseases, and all. But for asthma, we are yet to start in our country, but it's there for a long time in other part of the world, and it's very effective. Especially we can cut down on your high steroids, oral steroids, and patients' symptom burden can be reduced to a very normal, near normal levels. So for the very carefully selected patients, the biologics are very effective. But you have to select your patient based on the phenotypes and the biomarkers. So if you basically whether you have high IgE levels or you have eosinophilic asthma, then you can use these biologics. To whom to consider severe asthma uncontrolled, and the confirmed phenotypes are the eosinophilic or allergic with elevated biomarkers and frequently exacerbation patient with poor quality of life. So again, back to this picture. Now you can see here interleukin 4 and 13 is mainly involved in the production of IgE. So if the patient has more IgE levels, you can either use an anti-IgE like omalizumab, or you can use IL-4 or IL-13 blocker. If it is more eosinophilic, you can use IL-5 blockers. IL-13 is a, you can see it here, here, and here. So it's a more widespread, even for allergenic pathways. Again, IL-13 would be helpful. So likewise, so that is the interleukins. Then now for the neutrophilic, you have some of these lymphoid particles, TSLP, and this is also a biomarker that you can be used in treatment. So I'll be very brief with the treatment. So anti-IgE therapy, omalizumab, can be used if the IgE levels are high. Anti-IL-5 treatment is there, bepalozumab and resilumab and benralizumab. So these things are not available. Any of these things are not available to us. Dupilumab is again anti-IL-13, which has a more wide spectrum and even can be used in atopic dermatitis, and also, as mentioned by Neranjan earlier, can be used for COPD with eosinophilia also. So there's a wide range of uses in these things when they come into play. Then there are other newer things like tezepelumab, which is the non-eosinophilic pathway, and there are some other newer treatment options as well. So this is a summary of all these biologics. So I'll be very brief because we don't have these things at the moment, but hopefully we are hoping that we'll be having in the future. But the problem would be the cost, and of course to select the appropriate patient. So with that, I think we have come to the end of my talk. So severe asthma, it is difficult to control asthma even with high dose of inhaled or oral steroids or other controllers, and the patients become dependent on this treatment. And it's very important to identify the asthma phenotypes when you are talking about severe asthma, like mentioned by all the previous speakers earlier. Whether it's allergic asthma, eosinophilic asthma, or non-eosinophilic, non-allergenic asthma. And of course, treatment, there are different options. Some of options are available to us, but we are waiting for these biologics, and hopefully we can use them in the near future. So thank you very much. So World Asthma Day we had recently. So hope that all these lectures would educate the doctors, and then in turn you will be able to educate your patients. So it will be a good exercise. Thank you very much.